Welcome back. I'm Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. You're probably wondering, why the heck is Anthony showing me this MRI? I'm showing you because you can clearly see that there's a pathology occurring. It's related to vitamin B12 deficiency. We're going to talk about that and much more. This is the Macrocytic Anemia section. Make sure you have your book. I don't have to tell you that. You're not procrastinating. You got your book a long time ago, didn't you? Marking it up, taking notes. It's beautiful, isn't it? Look at all the knowledge you've gained and reviewed so far. You make me proud. You're making your parents proud. You're doing a good job. Macrocytic anemia. Macrocytic anemia, as you know, is anemia with an MCV that's greater than 100 micrometers cubed. Macrocytic anemia is usually caused by folate or vitamin B12 deficiency, especially at the dreaded test, right? You know about megaloblastic anemia. Folate and vitamin B12 are required for synthesis of DNA precursors. Folate circulates as methyltetrahydrofolate in the serum. The participation in the synthesis of DNA precursors is made possible by the removal of the methyl group. The transfer of the methyl group to vitamin B12 occurs under normal circumstances. The subsequent conversion to homosysteine by vitamin B12 results in methionine. The synthesis of DNA precursors is impaired by a lack of folate or vitamin B12. Megaloblastic anemia is caused by abnormal red blood cell precursor growth and cell division. Hypersegmented neutrophils result from granulocytic progenitors that fail to divide properly. That's why the polymorphonuclear cells, or neutrophils, appear to have many lobes because they're not dividing properly under vitamin B12 or folate deficiencies. Megaloblastic change can also be detected in rapidly dividing epithelial cells, such as those in the intestine. Causes of macrocytic anemia include vitamin B12 deficiency, folate deficiency, certain drugs like 5-fluorouracil, liver illness, and alcoholism. Now, you've probably seen 5-FU, 5-fluorouracil, in some section in your studies up to this point related to treating certain types of cancers. It should be clicking together because 5-fluorouracil interferes with DNA synthesis at that level via the mechanism that also promotes macrocytic anemia, right? Here we have an MRI image of the brain of a patient that has vitamin B12 deficiency. Note those abnormal lesions that are circled in the periventricular areas, suggesting white matter pathology. Note that folate deficiency refers to a lack of homeostatic levels of folate. Green vegetables and some fruits provide dietary folate. Folate deficiency develops within months, right? The body can go for months until it's folate deficient to a pathologic level. Folate is absorbed in the jejunum due to low body storage. Causes of folate deficiency include poor diet. For example, if an alcoholic patient is drinking too much and not eating their proper food, or an elderly patient who is in a home somewhere, possibly not being taken care of appropriately. Increased demand can cause an outpacing of folate utilization, leading to a folate deficiency. For example, in pregnancy, that's why pregnant mothers are encouraged to have proper folate levels. Also, this increased demand could happen in cancer and hemolytic anemia. Folate antagonist medications such as Methotrexate, which inhibits dihydrofolate reductase, can also result in folate deficiency. Clinical and laboratory findings of folate deficiency include macrocytic, large, greater than 100, macrocytic red blood cells, and hypersegmented neutrophils, more than 5 lobes. The normal amount of lobes that a neutrophil should have is 3 to 5. Folate deficiency can cause it to be hypersegmented, and then the neutrophils in the peripheral blood smear may have more than 5 lobes, like 6, 7, 8. There are conditions where the number of lobes in a neutrophil can be decreased, such as a Pseudo-Pelger-Hewitt neutrophil, a condition known as Meheglin. But for your purposes, know that in macrocytic anemia due to folate deficiency, you will see hypersegmented neutrophils. Also associated with folate deficiency is glossitis, which is inflammation of the tongue, low serum folate levels, increased serum homosysteine, which increases the risk of thrombosis, and normal levels of methylmalonic acid. With regards to vitamin B12 deficiency, vitamin B12 deficiency refers to a lack of homeostatic levels of vitamin B12. Proteins obtained from animals are complexed with dietary vitamin B12. Vitamin B12 is released by salivary gland enzymes such as amylase. You know about amylase, that enzyme that breaks down starch, right? Vitamin B12 is released by salivary gland enzymes such as amylase and then bound by R binder, another salivary gland enzyme, and passed via the stomach. Vitamin B12 is released from R binder in the duodenum by pancreatic proteases. In the small intestine, vitamin B12 binds an intrinsic factor that is produced by gastric parietal cells, right? You know that. Gastric parietal cells produce intrinsic factor. The ileum is where the intrinsic factor vitamin B12 complex is absorbed. Due to high hepatic stores of vitamin B12 deficiency is less prevalent than folate shortage and takes years to develop. Causes of vitamin B12 deficiency include pernicious anemia, veganism, pancreatic insufficiency, and terminal ileum damage. And all of those should make sense, right? Because with pernicious anemia, there's no development of the intrinsic factor, can't absorb B12. If a person is vegan and not taking their proper nutrients or getting their proper food, what have you, they're prone to not ingest the food that has B12 in it. With regards to pancreatic insufficiency, might not have the enzymes to cleave vitamin B12 so it can be absorbed. And obviously terminal ileum damage, if that area of the GI tract is damaged, there will be no absorption of the vitamin B12. Pernicious anemia is the most typical cause of vitamin B12 deficiency. Intrinsic factor deficiency results from the autoimmune loss of parietal cells in the stomach's body, right? You remember the parts of the stomach, the body, the fundus, the antrum, the pyloric sphincter. Damage to the terminal ileum and pancreatic insufficiency are two additional factors that contribute to vitamin B12 deficiency, such as Crohn's disease or Diphyllobothrum latum, the tapeworm. Except in vegetarians, dietary deficiencies of vitamin B12 are uncommon. Clinical and laboratory findings of vitamin B12 deficiency include macrocytic red blood cells, so large red blood cells, greater than 100, hypersegmented neutrophils, glossitis, and even subacute combined degeneration of the spinal cord may occur. Regarding some biochemistry, methylmalonic acid is converted to succinyl-CoA with the help of vitamin B12, which is an important in fatty acid metabolism. It's an important part of fatty acid metabolism. Vitamin B12 deficiency results in increased levels of methylmalonic acid, which impairs spinal cord myelination. And that's why there's issues with the myelin sheaths with vitamin B12 deficiency. And would you look at that? We have an MRI, T2 weighted image there to the right. Myelination damage leads to impaired vibratory feeling in the posterior column, spastic paresis, and poor proprioception due to impact of the lateral corticospinal tract. Fortunately, treatment of vitamin B12 deficiency is vitamin B12. And that's it for this. You know all about macrocytic anemia now. At least everything that is important to know. Make sure you got it down. Updated versions on the website. Utilize this. Supplement your studies. Make sure you're going through and doing the reading. Keep up the good work. Keep making us proud. You got this. And I'll see you next time. Take care.